So I hope you have gone through and there are not any major issues. Just quick recap. In the anterior medial compartment, we talk about quadriceps. And we said their nerve was femoral nerve. For the medial compartment, we talked about they are adductors and their nerve was obturator nerve. So now, before starting our today's session, I like to add on some more. I have started adding these asynchronous activities, so they are designed in a way so they can help you little bit extra. So I am thinking that I will create a lecture, a separate lecture that will be talking about only the nerves, the arteries, and the veins of the thigh. And that will be covering these nerves and these arteries, and there are so many things which you have seen and which you'll be seeing and where you are expected to be good at those. So that lecture shortly I'll be posting it. But don't ask me, I'll be posting it after I'll complete the tomorrow's lecture. That's a really, really important concept and we need to understand. So now, without any further delays, so I like to start. So my objectives, they have been mentioned to you, you can read it yourself. So now I like you should look in your screens because then you'll be connected. You can see the transition, the animation part of what's going on. So if you're not opening your Zoom thing, then probably you're missing out. So what I'm showing you right now, in front of you, you're looking at the hip joint. Relax, he will do his work, but in the meantime, we'll be continuing our stuff. So you're looking at the hip joint, coxal bone or innominate bone articulating with the upper part of the femur. So that is the posterior orientation, and something gray has been shown, which has been shown, it's a ligament. And we'll be talking about these things shortly. So what are these things and how it can go about, that we need to understand. So let's work on that. These are the labels, nothing new. I hope people know about these things because you had so many sessions which talk about the different parts of the innominate or the coxal bone. I'm just labeling the different parts which belongs to the ilium and ischium and pubis. Sacrum has been shown. So you're looking at these different landmarks which you need to be good at it. So now you are explained about the gluteal lines. Dr. Ayman spent good time in talking about these lines. And he gave you a good, on Thursday, last Thursday, he spent good time in explaining anatomical position and everything. And that is for your journal orientation. And now on the basis of the location, how this bone is placed in my body, we can name these lines as the posterior. You know, the outer surface of my ala of my ilium, we call it gluteal surface. So there you are looking at the posterior gluteal line. Then you are looking at which one is there. Tell me, those who are sitting here. I'm removing the label. So now tell me which label is coming. Where? You don't see it? I don't know. Get a good device. So, you have seen the posterior gluteal line. You have seen the anterior gluteal line. Now he has ruined my device. And then we are looking at inferior gluteal line. I hope now it will be visible for you. So these are the lines, and this is my, just at the acetabulum, this landmark is what? Simply the acetabulum part. So, and what is that part? Spine of the ischium, ischial spine. Thank you, Faisal. So now there is another ligament which has been shown in this image where you can see this ligament. If you go there, you can see this ligament down where I'm trying to put my cursor. Can you see this one? So this one is going from the sacrum to the spine of the ischium. This one is given a name. Give a name to this ligament. From ischium to sacrum, a ligament. Maybe you give a wrong name, who cares? Sacrospinous, yes, good. Sacrospinous ligament. There you go. Guys, learn to use common sense. You all have it, but underutilized. Use it more, you'll be more smarter. You'll be more sharper. So, and what about this? From sacrum to tuberosity. Suggest a name. Sacrotuberous ligament. There is no rocket science here. Are we good with that? Now, you're look at my arrow. Guys, when you're attending, no matter sitting at home or sitting at the classroom, if you're not attentive on the screen, you cannot see the transition of the animation. And if you cannot see the transition of the animation, then the whole concept destroys. There is no benefit. Then sleep, watch at your comfort. No need sitting. So this is my greater sciatic notch. It is named because my sciatic nerve is passing somehow in this area. It is living in this area. That's why it's called greater sciatic notch. And when I use the term greater, it means I have someone else as well. And who's that someone? That will be my lesser sciatic notch. So we'll be having a greater sciatic notch, and then we'll having a lesser sciatic notch. We need to be good at it. And can you see that somebody divides them? There's a ligament. And now these notches, they have become a foramina. If you see this notch, and on the other end, you can see there is a ligament which is going all the way. So now this becomes a whole of foramina. So now what is this structure? This is the rami, the superior ramus of my pubis bone. And then we are looking at the body of the pubis, and this is another inferior pubic rami. So pubis has two rami, and they are going towards the ischium to articulate and to make this foramina, which we call it as the obturator foramina. Can you see it there? So that's my obturator foramina. And what is this structure? What I'm talking, this structure. That is my pubic symphysis. We talk about it as an example of a joint, if you remember 50 years back. And who's that? Can you read it for me? What I'm asking this structure. Can you read it for me? Thank you. Now who's this? Ischial tuberosity. So now you can see that this point number 1, I get a foramina and I get a foramina. And this one is my obturator foramina. And what is that? Femur bone, and it has its different parts. This is the head of my femur, and this is the neck of my femur. We talk about those when we were talking about the hip joint. And this is the greater trochanter and the lesser trochanter. Guys, these are something, if you're not good with them, they will be affecting you. When I'm using the word affecting you, I mean something. So you are expected to be not good, but very good with them. And there is a line here. What the name should be given to this line? Intertrochanteric line. On the posterior aspect, we'll call it intertrochanteric crest. So this is the posterior aspect. So I'll not call it intertrochanteric line. I will call it intertrochanteric crest, because I'm looking from backwards. Because why I'm looking from the backwards? I had just shown you the gluteal lines. Gluteal lines are not present on the anterior aspect of my ilium part of the innominate bone. These gluteal lines are located on the posterior surface, because In between these lines, I will be attaching, I will be giving the proximal attachment of my gluteal muscles, and they are contributing in making our buttocks. So now, on to this upper part of the proximal part of the femur, we have the gluteal tuberosity. That's an area where one of my major gluteal muscle is being attached. That's the distal attachment of my gluteus maximus. And then this is being given a name. I must spend million of hours on that, linea spera. But don't go in those details. But you should be knowing this is linea spera. If you don't know it, you are affected. But so many muscles were attached, you guys are lucky. But we were those who have to remember them, who have to mark in front of the teacher that where what is attached on a dry bone. That was part of our finals. And there were so many small threaded lines you can draw on a piece of paper, but drawing them on a real bone, that's a skill. And we've been through. So now, I hope everything is clear on this slide. Any question, any concern, any ambiguity? Okay, so I'm zooming in. So now that part which we were talking, it is on top, and I have added the full femur. And then you're looking at the lower end, the proximal part of the tibia and fibula. So that you're looking at the posterior aspect of the knee joint. So let's chip in here the gluteal region stuff and the posterior thigh. So now what do we have here? A key muscle. I use this term. That's a key muscle. It acts like a key. It's a reference point. What do you mean by a key structure? If I'm new in Riyadh and a friend of mine who has invited me to visit for anything, now I know nothing. He told me, come on Malik Fahad Street. I said, where it is? I Googled it out. I saw it. It's a long street. It's not a small road. It's a long journey. It has a northern part, it has a southern part. So I asked him, where exactly? So he gave me a reference point. If you come in the middle part, you can see a specific building, a specific tower, your Kingdom Tower. I don't know what is a Kingdom Tower. A building which looks like an old model phone of Nokia. It was like that. So if you see a phone like Nokia, so there's a building which resembles that. So now I have a reference point. I have a key point. Then I was told, just stay next to that building. So now I can distinguish where is that building. Even my Google Map, Google World, everything will show me that. So I can direct the cab driver, just take me to this part if I don't have the coordinates. So I can be there, and that's it. So in identifying structures, this muscle acts as a key, and this key muscle is given a name. We call it piriformis. How it acts like a key, you'll be looking at shortly. And you can see that this muscle is emerging from the sacrum bone, and it's going to be attached into a fossa, into a cave-like structure, into a depth which is located in between my greater and lesser trochanterids of the femur. And then you can see a muscle which has been shown on the top. We talk about those lines, and that is the attachment of my gluteus medius muscle. And then who are these? These are my hamstrings, the muscles who will be studying in the posterior compartment of the thigh. I'm sure everybody knows about hamstrings because when you watch your favorite game, soccer, your favorite player in finals, oh, he's on the floor. Everybody's now stressed. What will happen? How my team will win? Because our key player is on the floor, is on the ground, and they have announced he has a hamstring problem and he's been thrown on the stretcher and taken out to the hospital. Fine, my team may be losing. So what are those hamstrings? Hamstrings are a group of muscles who live in my posterior thigh. And so many muscles contributes here. And we need to know about them. Are we good so far? Now, these are the hamstrings. And these hamstrings What are they doing? There are their names. So they are semitendinosus, semimembranosus, and biceps femoris. This is a different biceps than the bicep which I have in my arm. Now, there's a big nerve, the biggest nerve of the whole body, thickest, biggest, bulkiest, and that's my sciatic nerve. It's coming from sacral plexus. We learned that in our body, we have four major plexuses which are coming from the spinal nerves. Out of them, you know one. That was brachial plexus. Above to that, there is one which is for my neck region, is called cervical plexus. For the lower segment of my body, for my lower limb, we don't have one, we have two plexuses. One is lumbar plexus and one is the sacral plexus. Why they are called lumbar and sacral? Because these spinal nerves are emerging from the lumbar vertebrae and the sacral vertebrae. And they are the one who are giving us femoral nerve, obturator nerve, and sciatic nerve. And this sciatic nerve is the primary supply of my posterior thigh. Then whole of my leg, whole of my foot. Primarily, they all are innervated, controlled by this sciatic nerve and its branches. Are we good? So femoral nerve, it's only an exclusive nerve for front of my thigh, like musculocutaneous nerve. In upper limb, we learn about musculocutaneous. It was doing what? It was supplying the flexors. Thank you. It was supplying the flexors. Then you can say biceps and coracobrachialis and brachialis. So same like that, my femoral nerve is for my quadriceps plus sartorius. And after completing that part, it becomes a cutaneous branch, a sensory branch. That is from lumbar plexus. Obturator from lumbar plexus. And now the sciatic from sacral plexus. It supplies posterior thigh. Then it goes down. And from the sacral plexus, I derive separate nerves. Guys, these plexuses are not that nicely explained in textbooks like was brachial plexus. But we'll be talking about those. Relax. In my lecture where I'll be talking about the nerves and arteries around the thigh and around the hip, I will complete all these tasks in that asynchronous lecture. So this is sciatic nerve which you're looking at. Now what is that? Thank you. I'm glad people now identifying things. So that's a bursa. It's on my trochanter. We call it trochanter bursa. We all know what a bursa is. Now, somebody has covered everything. It's a big one. If you put your hand on your butts, this is that muscle. Gluteus maximus. You see, it is maximus. It has covered everything. All is hidden inside. So this is my gluteus maximus muscle. You have seen gluteus medius, but not completely, part of it. And then the nerve supply for my gluteus maximus is from inferior gluteal nerve. From where I'm getting this? This is from the sacral plexus. And now, everything else, don't take a wrong message here. This muscle is under the deep fascia. It's been shown in this image that it is outside the deep fascia. No, just to highlight to you. Otherwise, everything is enclosed in this thing, and that we gave it a name. This was a deep fascia of my thigh, and we call it fascia lata. I learn it from latte, coffee latte, any latte thing. So fascia lata. So that's the deep fascia of my thigh. Now, that's just the name. So now this is what a band-like structure. We spend good time on that. This is my iliotibial tract. And this is a really important feature in stability of my knee joint. While my knee is in extended format. This is my iliotibial tract. It's like a band. Now, gluteus maximus, what it is doing for me? It's a powerful extensor of what? Flexed thigh. What do you mean by flexed thigh? I'm sitting on a chair. I'm rising from there. That's the time. If my thigh is flexed, now it is, if you do like that, just put your hand on your gluteus maximus. While you're standing, put your hand on your gluteus maximus. You'll feeling a different texture. And while you're doing it, you'll feel it is contracted. It becomes more contracted. It becomes more rigid. So it is when a powerful extensor, when my thigh is flexed. So you need to understand. These are, when you're climbing stairs, this is the primary muscle which helps you to climb. And guys, these are the major functions. It has other functions as well. But first learn the prime ones. Okay, so now what I'm writing here, intramuscular injection. We talk about intramuscular injection when we're talking about deltoid. For that reason, this is visible outside. Otherwise, it could have been under D fascia. So now, you've been as a doctor. Where should you give an intramuscular injection? That's important. Because one simple injection can change a lot, can destroy your hamstrings, or can give you a cure. So why that is happening? Let's see that. So intramuscular injection, don't draw a line on your patient, please. It's in your brain. It should be in your brain. Divide it vertically. Then go from these reference points. You should be knowing. You are going from greater trochanter and medially you are going towards what? Which part of the sacrum? You need to be good at it. So you divided, primarily you divided your gluteal region into 4. And now the site where I should give injection, the safest site is upper outer quadrant. Why? A nurse can tell you, doctor, this is the place. How you know? I saw my senior. I saw my instructor. She taught me just give injection here. Why? Maybe she not knowing. But nowadays nurses are smart. So they might not be knowing the reason. Yes. Thank you very much. No nerves, but we cannot survive with this answer. Gentlemen, we need to know what nerve exactly. Thank you very much. Sciatic nerve. So we are preventing my primary. I gave you a hint before. My hamstring will be gone. There's a chance. If I have a very irritable and very notorious type of material which I'm about to inject, why I'm injecting an injection in my gluteal region? Why not in deltoid? Any reason for that? No. There are certain medicine. They are so painful once they are injected in the deltoid. Maybe your hand go freeze and it hurts for a week plus, and then you regain. And there are certain injections which should be given deep intramuscular injections. Deep intramuscular injection. For that reason, you prefer this site. There are other sites. I'm not talking about those today. So this is an injection site for deep intramuscular injection. And this is the safest area. Now you can see this tracking, this yellow dotted tracking. It's showing you the pathway of sciatic nerve. So you are far, far away from sciatic nerve. But remember, the simple way, when you are injecting, we have to be very careful. You inject the needle, always withdraw it. You never know, you have entered into a vessel. The injection which has to be given intramuscular, to be avoided, not to be given in a vein or in artery, we never give an injection. So many injections, and on the box it's written IV, I/V or I/M. So those who are designed for IV, they should be given in the veins, and those who are designed IM or IG, they should be for muscle. You have to be very clear, because when you'll be learning pharmacology, then you'll understanding what is that difference and why we have, because of, you see every injection, if you buy injection, you have seen an injection, it comes usually in a powder form. And along with that, there is another bottle which contains either water or it contains some oil-based suspension. So on the basis, so IM injections should be given through an oil-based suspension, and the IV injection are usually given with the distilled water. So there are differences, and we need to understand all these things. But not this is not the time. But for a general orientation, you should know it. So you have to be specific, and there are other structures as well are there. So the prime thing is to save my sciatic nerve, but there are other things as well, and you have to be knowing those. So this is my sciatic nerve. That's important. Now let's go back again. I'll take it after. So now we were good about these structures, we talk about those. So now this is a gluteus maximus which has been cut and reflected so that we can see inside things. So what are those inside things? This is the gluteus maximus. A part of it is being removed. This part has been removed. From here, this is the cut edge, there is the cut edge. So intermediate part has been removed so we can see what is inside. So on top was gluteus maximus, then you are looking at the medius, and I have removed some part of that. Going further, so this is inside that. If I don't deflect this medius, I cannot see the minimus. Can you see the difference in colors? This will, and this has been, when these structures has been labeled, I try to follow the same color scheme. So you can connect, there are no lines, because if I put lines, the whole image will be distorted. So each color denotes what muscle it is. So you're looking at medius and maximus, and this is my minimus, the pink color. Are we good? So these are three major gluteal muscles. And then we have a series of, and who's supplying them? So now my minimus, that is innervated by what? Both medius and minimus. By which nerve? Superior gluteal nerve. And maximus was by inferior gluteal nerve. Guys, these points should be very clear. Yesterday in TPL, I was asking about tensor fascial lata muscle. That was also innervated by which gluteal nerve? You look back. So now, in the meantime, someone has emerged, goes transversely, that is piriformis. I talk about it, it's a key muscle. Let's see how and why we call it a key muscle. Now, piriformis, it has a special nerve for himself. Nerve to piriformis. It's so special. And below to this, now, can you see this brown band? These are tiny muscles, and this is my superior gemellus. Then superior gemellus below to this should be, but before that, I have obturator. Which obturator is this? Externus or internus? Obturator internus. Why obturator? Because it's coming from the obturator foramen. Internus present internally. Then I have inferior gemellus. If you look at the pattern, piriformis, superior gemellus, obturator internus, and then inferior gemellus. So this is the pattern. Now, there is a muscle, this muscle. It's quadrangular. It has a name, quadratus femoris. You have seen a quadratus muscle before. Remember the deep flexor layer of your forearm, pronator quadratus. Now connect the dots. That muscle was also having 4 angles. A quadratus of femoral region called what is called quadratus femoris. A quadratus of my forearm called pronator quadratus. A quadratus of my abdomen also, quadratus abdominis. So we have this word quadratus used at different places, but you should be able to identify. These are, I call in your language, mutashabihat. They resembles, because this quadratus word is used different places. So on the basis of the appearance of this muscle, we name it like that. Are we good? Okay. Going further, This is the nerve supply. Then there's a tiny thing has been emerging in this image. Can you see that? This one. Who's that? Any idea? We talked about it yesterday. Tensor fascial artery. So this tensor fascial artery is present laterally and slightly anteriorly. So you can see from anterior compartment, you can see from posterior compartment, and you can see from lateral side. In where? In gluteal region. Are we good so far? Any question emerging? We have not learned sacral plexus, so don't get in L4, L5. We'll talk about it. When we will be learning the sacral plexus and the lumbar plexus, we're learning them together because they are interconnected. Primarily, my sacral plexus is giving sciatic nerve, and rest of the things are emerging from lumbar plexus. Few of them, obturator, femoral, but there are so many others as well. And they are really, really important and we need to know about them. But I don't, when I teach, I go with a plan. I don't give you everything in one go. I keep layering up the thing. If I give you everything in one go, then you will not be able to swallow it. You'll vomit it out. So, when you eat a pizza, can you eat the whole pizza like this? It goes in your mouth? No, you make a chunk. Wedge, and this wedge is designed a triangle. It goes in your mouth. It's designed the narrow to broader part, but not a full bread goes in your mouth. A thick 10 incher. Can you eat in one go? I wonder. I cannot at least. And if I give you the thickest pizza I have seen is Chicago. This thick. That's the thickness of that pizza. Anyway, we'll talk some other time. So, these are the nerve supply of these muscles. And now, there is my favorite, sciatic nerve. It's passing. Look back to my piriformis, below to piriformis. This is the common trend of emerging of sciatic nerve. So any nerve, any broad band, which don't look to your nerve, it's so big. Those you have seen, and today you'll be seeing in the labs, how thick it is. So below to what? Below to my piriformis muscle. One. Then what I have? Someone else is coming with that, sharing. Who's that? Posterior femoral cutaneous nerve. That is coming from there as well. Now, let's add up more things. What is happening? Actions of these muscles. What are they doing for us? Let's review that. So gluteus medius and muscle, what it is doing? You have to know with that. I'm not reading right now because you can read the slides. Maximus, minimus, what are their functions? All has been mentioned. So these are, guys, remember, when I post my resource material, there are some tables. It's not necessary that the table which has derived from a textbook, it should match with my textbook. There are so many differences. So then you'll write always, I get this question so many times, which one is right? Both of them are right. There are some different orientation. So if you get into any conflict, you should refer to what? You should refer to your standard textbooks, and your standard textbooks are Grays and Moores. Whatsoever is written there, that is the final word. Okay. So going further, so these are my actions of all these muscles. Now, piriformis as a key muscle. Can you see that two arteries are coming above to my piriformis? Region is gluteal. Can I call them superior gluteal arteries? Why I'm calling them superior? Because they are coming above to the piriformis. So I call them superior gluteal artery. Now, a nerve, what should I call? Superior gluteal nerve. And now below I have an artery. What should be the name? You can guess yourself. Inferior gluteal. So who's the reference point? Piriformis. So I'm getting superior and inferior gluteal nerves and vessels. Are we good? So that's how, if I am able to identify piriformis, I can identify all the sequence of the muscles and all the sequence of the blood vessels and the nerves. That makes him a very important landmark. Now, this is going down, internal pudendal artery. We will not be talking much about this artery at the moment. It's been accompanied by pudendal nerve. These are to be supplied in the deep pelvic regions. Those supplies we are not talking at the moment. So you have seen now inferior gluteal artery, superior gluteal nerve, inferior gluteal nerve. Are we fine? Now we are good with this so far. One of my hamstring, it's like a tendon. Why I'm saying it's like a tendon? Look at it, the lower part. Semi-tendinosis. The nerve supply, all my hamstrings are innervated by tibial part of sciatic, because sciatic has not divided. So I'm getting a branch from sciatic, but that is exactly coming from the tibial part of it. And this is the action of this muscle. All of them, if you forget, all these hamstrings are strong flexors of your knee. And then someone who's flat, like a membrane, we call it semi-membranosis. Same nerve supply, same action. It reflects backwards. Then I have a muscle which crosses, and that is my biceps femoris, its long head. Can you notice all of them, they are coming from one common place. And now they are attached in different parts of the proximal tibia or fibula. So one who's going laterally is called biceps femoris, that is its long head, and the short head will be visible shortly. This is the short head. The difference in nerve supply. The long head, same tibial part of sciatic, but the short head is innervated by common fibular nerve. That's the difference. So any difference? Are we good so far? So these are the hamstrings. This is my sciatic nerve, who will be, when it will be reaching close to my knee joint posteriorly in the popliteal region, there usually it bifurcates into tibial nerve, and one who goes laterally is common fibular nerve. Your old books writes it as common peroneal nerve. So don't get me, what the hell, what is this? Is this wrong? No, no, that's not wrong. That's an old name, and this common fibular is a new name. You can see it's dividing into tibial and common fibular. This is my gluteus maximus. Now, if I remove gluteus maximus, everything is visible to me. I put it there, everything is covered. Now, everything goes back. Are we fine with that? Iliotibial tract. I'm not touching this concept at the moment because it needs time, and my time is only by my watch, and I have 6 more minutes to go. So I'm skipping this slide at the moment, and I have something more for you guys. So get ready for that. Guys, I'm launching a poll for you. These are some questions which we have talked today. So poll is on. You are expected to answer these questions. Open your devices, get connected to Zoom, and reply. What do you think the right answers are? So only 19% have been participated so far. I don't know, they should get it. This glitch is beyond my control. Those of you who are not getting them, I will share with you, don't worry for that. But this is just for your continuous assessment. Judy, according to my window, it says more than 50% has voted. Yeah, yeah. Yeah, that's a few. So I think it's around 3 minutes have gone, so I'm ending this one here. So now I'm sharing the results with you. So guys, now we are approaching to end of today's session. I can see there are so many concerns and questions. I'll take it and I will be working on your asynchronous part of the learning. So far, so bye-bye.